Today we have Russell Gaynor. He's a licensed clinical social worker, received his bachelor's of social work from UT El Paso, and his master's of science and social work from UT Austin. A professional social worker for over 20 years, his work experience ranges from adult probation officer, sex offender unit, staff development officer, DWI education instructor, professional geriatric care manager, adjunct professor, and hospice social worker for over 18 years. Mr. Gaynor's specialization is in geriatric end-of-life care and in hypnosis and guided imagery. Russell currently works as a national hospice consultant for interim healthcare and is taking the time out of his busy day to help UT and the VA professionals hear this popular talk on the ethics of medical utility. So please welcome Russell Gaynor.
Thank you. It's always nice to have familiar faces again. Why don't we just do introductions so I know who my audience is, and we'll start over here if I may.
I'm a dentist researcher, and I've been with the grad for 23 years.
Did you say a thanatos researcher?
Dentist.
Oh, dental. Got it.
Yeah,
Sorry.
dental.
Okay. Very good. Thank you.
Your turn.
Mark in the South Texas Geriatric Education Center.
I'm Barbara Walls. I'm a registered nurse and the diabetes educator for the VA.
I'm Tressa Edwards now with the GREC.
Denise Minor-Williams, I'm an RN researcher.
Marie Brindle, Alzheimer's volunteer and South Texas Geriatric Research, I believe.
Check name tag.
Yes.
It's a pleasure to be with you this morning. The conversation came to me when working with the hospice patients and families and wondering what happens when you come to those crossroads where there seems to be this contradiction between what medicine seems to have the ability to offer and the values and desires of patients and family. And it's these conflicts that create the ethical dilemmas of our culture. And it's been fascinating to watch the evolutionary process of how the conflicts have arisen because of the advances in technology. And one of the things that I've learned is that just because we can do something doesn't mean it's always the best thing for us to do. So this presentation comes to us from the American Medical Association. It was a grant from the Robert Wood Johnson Foundation called the EPEC project, Education for Physicians at End-of-Life Care. And I've repurposed it and made a few modifications to the content just to help cover some of the ethical issues in this. For the objectives, we'll be looking at some of the factors that lead to feudal situations and help us to understand how to identify common factors, how to communicate, to negotiate, to resolve those conflicts, and look at some of the steps that we can take in a fair process situation to help meet the needs of the patient and family. Essentially, what I've discovered after learning about this material was my goal, especially as a clinician, working directly with patients and families, is to help us to develop practical skills in dealing with the clinical situations where futility is evoked. This is helpful because there's a therapeutic process that can be gleaned from going through such steps that are necessary in this climate of high emotion in these kinds of situations. I see how that works, all right? It's interesting to note, a lot of times it seems to be the conflict arises from the physician's statements or information that they have. And we see that there are some times that physicians in futility that we get so attached to the types of treatment that were provided that we have a difficulty seeing beyond and seeing the bigger picture. So one of the examples would be like a dialysis patient. especially when the family or the physician has been so ingrained in doing this procedure over and over for many years, and it becomes something that's habitual. We also may see that physicians or other professionals can be invested in those interventions. I've had the opportunity to work with some oncologists who are very attached to the chemotherapies, and they seem to want to be able to treat that patient up until there's no treatment available anymore. And where that line is becomes very gray sometimes. I think what's important is that at any time, any party within this conversation can say, I think this is futile. Whether it's the professional, whether it's the patient or family, or whether it's the outside observers as part of a team. So what do we do when we try to define medical futility? Well, some say that it's a treatment that won't achieve a patient's goal. And that's an interesting question, because what I found that one of my best practices is when I go in to meet patients and families is start that conversation by first, tell me what the doctor's told you. It's always helpful. I think many of my colleagues have done the same thing by going in and saying, okay, so I see you have cancer and we're ready. And they're going, cancer, what? Yeah. And suddenly we have a whole different conversation. So starting off with, what is it that you understand? And the next question then becomes, what is it we want to accomplish? What's the goal? Some definitions of futility say that there are treatments or types of care that serve no legitimate goal of medical practice. And that could be a definition of futility. Or if you wanted a really strong line, you could say it's a treatment that is ineffective more than 99% of the time. Or sometimes a definition of futility could be inclusive of something that doesn't conform to acceptable community standards. So is there really futility in a case? What we see is that unequivocal cases of medical futility are really rare. Most of the time what we see are miscommunications, value differences. These are the kinds of experiences that clinicians mistaken for the fact that there is a intractable conflict. What we find is case resolution is more important than any of the definitions that we could come up with. Because it really doesn't matter what we call it, it's what we're going to do with it. Having a fair process for resolution increases the chance that we can agree on what futility is going to be. And one of the things that we know about these types of situations is the conflict over treatment can lead to misery or have difficulty with resolution. Part of my work as a hospice social worker is doing bereavement care and providing services for patients and families after the fact. And it's always challenging to watch these families who had high hopes or expectations of the medical system and felt that their wishes were not honored in the process. Patients oftentimes will say, when I told the doctor I wanted hospice, he just gave up on me. He didn't want to see me ever again. And seemingly that long relationship they had together was terminated unexpectedly. We also see that the misery can be experienced by the family or even patients or professionals in the healthcare system. I know some of those most challenging cases that we've had are most memorable because they are the ones that still tug at my heartstrings. I remember this family and this situation. So what we want to do is try to find ways of resolving these differences. We have to do that by supporting the patient and family. And we need to base these decisions on informed consent, advanced care planning, and goals of care. This requires effective communication and discussion. This is not a very simple conversation. This is something that we need to take the time, sit down, face to face, and say, tell me your story. What's important in this situation? When we come up with why there's disagreement, probably the best thing that we can do is go back to what's the goal. When I'm teaching the hospice staff, that's one of the things I tell them. This is the holy grail. That's the goal that needs to be set up on the mantle, and anything that comes up, we refer back to that goal and say, how is that going to help us in accomplishing that goal? That conversation is tricky though, because sometimes there are a lot of layers involved. So the first question would be, tell me what the doctors told you. The next question is, what's the goal? You know, Dad was a robust kind of guy. He loved farming, and we'd love to have him back on his tractor mowing the back 40. Say, you know, that sounds outstanding. I'd love that too. But do you really think that's realistic? Now, given all that's going on, I don't suppose it is. So the layers that we have to work to uncover make this a meaningful process and will help with that barrier or perceived conflict. When we're looking at differential diagnosis, some of the times what we'll see is that we're actually looking to an inappropriate surrogate. A lot of us who have advanced directives, yes, have assigned or designated our significant others in our lives as the person to make medical decisions. And that may have been appropriate 10 years ago. But now that we have both changed in health status, maybe, and what we see a lot of times, maybe the spouse is no longer the most appropriate because they're compromised either cognitively or physically, or it just may be beyond their kin to be able to manage these kinds of conversations. But because it's on paper, because we have this advanced directive that says you're the surrogate, the system looks to that person. And that's when it becomes challenging, because the children frequently say, well, Mom, it's up to you. But Mom doesn't have the wherewithal to pull up a cogent discussion or meaningful dialogue about what that means for them. We'll also see misunderstandings, personal factors, and values conflicts. So let's look at a little bit of some more of this. Of course, you have the patient's stated preference when we're talking about surrogates. And I have had occasion where the person that was the medical power of attorney was the ex-wife, and he was in a new marriage. And we all kind of went, really? That's going to be interesting. But that person knew him best. It was an amicable dissolution of the marriage, and that was the person that he felt could represent his wishes for what his healthcare needs were. Sometimes when we don't have a person in writing, there is a legislated hierarchy. First, we have to figure out, is there a guardian in place? If there's not a guardian, then there's a spouse. If there's not a spouse, then there's adult children. Now, we've all encountered families that have multiple children, maybe 6, 12. How do you figure out how we're going to do that? The way that in Texas the standard is applied is by saying a majority of readily available. So we may have 6 kids, but 2 of them live here in town, and those are the 2 present, that's the majority that are readily available, and that's where we live. If there's no children, then we can look to siblings from that person, and then distant relatives. And in extreme cases, especially in hospital settings, we would invite clergy to be a part that may know the patient's wishes. But most importantly, we need to know who is it that's most likely to know what the patient would have wanted. And I wrestle with that because I have been asked by some peers to act as their medical power of attorney because they don't have family. And I know what I would want, but that doesn't mean that that's what I have to advocate for. So part of that dialogue for me is a conversation of what is quality of life to you? When you know that things no longer work for you, how can I tell? What's that look like? A good colleague of mine who has rheumatoid arthritis and has lots of complicated health problems because of that asked me to act in this capacity for her. And so part of that conversation was, I know for me that if I can't have meaningful interaction with my environment, that's it, I'm done. I don't want to have biologic function continue. And she said, you know, because for me my mobility has been so challenged all my life, if I can't move around on my own volition, that for me ends my quality of life. So different standards because of her life experiences. But that's the question that we need to find out in this conversation. Who is it that's most likely to know what the patient would have wanted? And who can reflect those interests best? Does the surrogate have the cognitive ability to make decisions? That's another situation where we look to the spouse, usually an elderly person, after several days out of their environment in the hospital setting, they become compromised and they no longer have clarity of decision making. And that added to the emotional toll of what's going on and all the hostile environment of the setting makes it even more challenging. So sometimes what we want to be able to do is encourage a more collaborative approach. Instead of saying, well, you're the person on paper, you have to make the decision. How about we let your kids decide, and if you agree with it, we can move forward. And that seems to be an acceptable compromise. Some of the other issues that come up when we look at feudal situations is misunderlying those diagnosis or the prognosis. There's lack of clarity. We see inappropriate language being used or inappropriate feedback provided. I'll never forget walking into a hospital situation. I was the social worker coming in from the hospice to introduce the program. There was a social worker from the hospital that was visiting the patient. Now this was a 92-year-old farmer who had COPD, respiratorily compromised, not a whole lot of education, and she was presenting an out-of-hospital DNR for him. And in that conversation, she looked at him and said, this paper means that you don't want pulmonary resuscitation, artificial airway management, and continue to read on the litany that is the technical terms for what it meant. And you could see his eyes glaze over, and he just kind of went, He had no context for that dialogue, no way of understanding what was being told to him. And so while technically it was a correct presentation, it did not speak the language that he was familiar with and therefore made it more difficult. And because of that, he didn't understand the meaning behind what he was trying to make a decision on. And so in that situation, that was a misunderstanding of what the underlying cause was. He didn't have clarity. We need to be able to assess those as we're talking and get that feedback. And then we need to know how to respond in ways that are useful. When we find conflicting information from healthcare professionals, a lot of times what we'll see are people hedging. Really, I don't want to give you the whole news. I don't want to tell you how bad it is. And we hold out for hope. This really doesn't do much for the family because they're looking for some information that they can act on. They need to know what options are available. And if we're not willing to at least put it out there and say, would it surprise you if he's not going to be here Thanksgiving? Then they have some decisions that they can make. So, we've talked about not knowing the diagnosis, and that's always a challenging one. Too much jargon, different or conflicting information. Previous over-optimistic prognoses or a stressful environment. I think one of the questions that I find a lot of times from some of the younger children or family members is they'll say, well, we want you to do everything. Well, that's a great concept. But what does everything mean? What does that look like? And when does doing everything become counterproductive? And that's part of the heart of this conversation of looking at a feudal situation is when you have that kind of a statement made without further investigation, then it becomes challenging to figure out what it is that we need to really start identifying to address to get this resolved. So you can ask questions like, well, tell me what you understand is going on. Or what do you mean when you think about doing everything? Or what do you expect will happen if we do everything? I like that one because that helps to get more to the root because we have this idea that more is better. Just go to any all-you-can-eat buffet and watch. more is not more life is not necessarily better because there's no quality at some point. Or going back to that initial question, what's the goal? What is it we're trying to accomplish? And if you want us to do everything, how does that help in achieving what that goal is? Usually when we ask the question what the goal, about what that goal is, it will be something like death with dignity, or comfortably surrounded by family and friends, or in their own environment. That's when that conversation looks different at that point. We also see sleep deprivation entering into that conversation. The emotional distress, somebody who's psychologically unprepared, or somebody with inadequate cognitive ability. What's the status of the primary caregiver, of the person that we're having a conversation with? And how can we help them navigate this? Because if we push and force for a decision when they're unprepared or unable, that makes that misery afterwards, that makes the bereavement challenges all the more significant. So, how to respond? Choose a primary communicator. Who is it that would be best able to represent these issues with them, especially when you have a large group? That's always challenging. We want to give information in small pieces, in multiple formats. Give it to them in writing, give them handouts, give them articles. Use understandable language. And understand that frequent repetition may be required. Check for understanding. Now that we've had this conversation, I'd like to imagine that you're going to have a phone call next. Would you tell me what you would tell the person on the end of the phone about what we just talked about? That's a great way of getting that clarity and having that conversation repeated back to you so that you can check for the details. Don't hedge to provide hope. That doesn't mean we have to be brutal and unsympathetic in our delivery, but simply giving them information that is usable is very helpful. I was talking this morning with a colleague who's new to the hospice field, and they were stymied by the presentation from the family when they said, we need to know how long this is going to last. How much time does he have? And this professional said, well, I don't know for sure. I said, well, if we think about the emotional content behind what's backing that question, what is it you think they wanted to know? And essentially it came down to, we're trying to figure out, is this a sprint or is this a marathon? Because that's the issue for the family is, how long do I need to hold my reserves together to get through this? It wasn't that they were in a hurry to get this over with. They weren't looking for something macabre. But what they were interested in was trying to figure out how emotionally to get through that. So I said, give them some time frames. We see patients have weeks to months. We see patients have days to weeks, hours to days, and sometimes we get minutes to hours. And with blocks of time like that, it becomes manageable. There are no guarantees, and we don't know for sure exactly the when. But given some time frames like that, it becomes something that is manageable. Encourage the families to write down questions. Bring them in. Next time you come in, we'll go through your list. Provide support. And importantly, involve other healthcare professionals in that conversation. This is not a time for people to act in a vacuum. This is when we get the rest of the team, the nurses, the chaplains, the social workers, in addition to the physicians, and have a conversation about how we might, as a group, support the patient and family through these changes. We also see in the dialogue about futility, personal factors that will come up. We'll see families who have a high distrust of the medical system. Well, they weren't honest to me at the hospital. They did things to us without telling us. Those are always challenging. Or they may have feelings of guilt. These interpersonal crises manifest as conflicts of futility. Their grief may be impairing their reasoning and their ability to interact. What will I do if she dies? What's going to be left of me or for me when my other half is gone? Those are questions that we want to go back to their family and say, you heard your dad. What are you going to do as a family after your mother's died? How is that going to make your family different? Again, it's the emotional content behind the statement that sometimes has the most ability to be important in moving away from this conflict. You may see a lot of intra-family issues, so calling for a family meeting is very valuable. Attempting to secure one person as that spokesperson to be able to relay information to. Situations where secondary gain are unusual and not the norm, but they do happen. I have seen families that say, well, if you can live beyond January 31st, or no, December 31st, we'll have insurance benefits for another year. I have seen families that say, well, the reason we want all life support kept on is because we want to see dad be alive when the baby's born. So those kinds of issues do come up. And so looking at issues of secondary gain can be valuable because now we understand the context in which this is presented, and that frames the discussion differently. We also may see the healthcare staff have personal factors. Well, this reminds me so much of my situation with my mom. Here's what I wanted to do. And I'm trying to resolve my own need in this family dynamic situation. So, again, helping to avoid some of these conflicts goes back into that conversation, understanding what's behind the meaning of what's being presented. And sometimes there are disagreements, disagreement over goals. One family that I worked with, the patient had gastric cancer. He was a very, I think he was a Pentecostal minister, if I recall. And the family's religious belief system was such that they were a name it and claim it family. That we're just going to claim this victory in the name of our Lord, and everything's going to be fine. And he's going to be cured and healed from this. And we don't have to worry about all the other stuff. Well, that was interesting. And I'm looking at this from a different vantage point, and I'm going, wow, I don't know that we have that much time. So I happened in the dialogue with the family, I asked, I agree with it, I think that would be marvelous. But on the off chance that doesn't happen, would it be a bad thing to make second range plans? Can we talk about funeral planning? What would that look like? And they were open to that as a possibility. I didn't push it as the agenda, but it was that disagreement over goal that made it very challenging to try to figure out the issue of life at all cost. We also look at issues of benefit. Hope for a miracle. I remember working with a 103-year-old lady, and her great niece came into town, and they asked someone from the hospice staff to go to the nursing home and meet with her. So I went over and we were chatting. She was on one side of the bed and I was on the other, and the patient was actively dying at the time. And we talked about what this looked like. Part of the conversation, though, was about the patient's DNR status, because this patient at 103 was a full code. And she was a little bag of bones and osteoporosis, and it looked awful. And I could only imagine the trauma from the staff if they had to come in and perform CPR. And so we were talking about her aunt's philosophy on this. And I said, I'm curious as to why she would be so adamant about making sure that we did everything, including CPR, at this stage. And she sighed and looked at me and she said, well, her religious beliefs were that when she dies, the people that have died before her will be on the other side waiting to greet her. And that was her father and 3 brothers who sexually abused her all her life. And so her value in keeping life going was to avoid that final meeting. So being able to identify these types of issues that go deeper than what we think is just a futile situation, and they have greater impact and ramifications, but only if we're willing to dig into those conversations. Those value differences for religious, marital, value of life, all come into play. We want to ask for understanding, especially on those religious issues. I'm sorry, I'm not familiar with your culture. Can you share it with me why this is important for you? Or miracles? Well, is it okay if we put other plans in place, just in case? Or is this consistent with the value of life as expressed by the patient? So, a due process. We first have to make those earnest attempts in advance. We have to open the dialogue. We have to be willing to stop, put our agendas aside, sit down and say, tell me your story. Why is it that this is important, and what does it mean to you? What is it that is going to help us achieve that goal? Nutrition and hydration come into play in hospice a lot of times, and we think that because a person no longer is able to take in food or fluids by mouth, that starvation is the next logical step. Sometimes with education we can move beyond that. But part of that conversation needs to be able to understand that there's an emotional quality behind what is being presented to us. So we need to be able to identify those situations in advance and be prepared to speak to them. Encourage joint decision making, especially when you have that elder surrogate who's not able to make those conversations or may not be able to participate. Negotiate those disagreements. This is where we would involve other consultants as well, bringing an ethics committee in, bringing a member of the clergy in, asking another opinion from a medical expert as well. And of course the institutional committees, most organizations will have an ethics committee that is willing and able to meet for those conversations. And in some situations, we just have to say, you know, this is not the right environment for me to be able to direct you. And I'm going to encourage you to seek out and change care to another physician. For a while, there was one of the nursing homes that I worked with in Castroville, whose policy was never to withdraw artificial nutrition or hydration. That if a patient got on it, they had to be on it indefinitely. And from a hospice standpoint, that makes more complications sometimes. And it was always challenging when we were working with families in that setting because we knew the next step that was coming, and we knew the position of the nursing home was not friendly to them. And so we had to negotiate those arrangements with the family and the facility and say, we will need to transfer, if you want to take this next step, we will have to move your loved one to a different facility. But that was okay for that facility at that time, because that was their policy, that was their standard. So making sure that we have those options available to the patients and families is something kind of in our last line of defense. Any thoughts, comments, questions at this point? What kind of situations that you've encountered would raise the futility flag?
Well, I had some, it was a really, it just points up the communication misunderstanding. I had a family member that I was helping care for, dying, 88 years old, dementia, had pancreatic cancer at the end of life, whose son wanted, he wanted like artificial respiration tried, but nothing else at the end of life. And the other family member said, that's crazy. That is just utterly crazy, and like it makes no sense. And, you know, and finally, but what I found out was, you know, this person the person who was dying had rescued this other person from a drowning incident and had provided that breath of life for him. And it was just this had this intense kind of like emotional meaning. It's like, okay, you know,
Wow.
yeah. I mean, yeah. So it's like, you know, just find out what's behind it.
Do you remember how you were able to move beyond that?
Well, I was with, this is my grandfather, and when he was dying, and I could make, I mean, you know, I know that makes no sense, but I could at least honor that, you know, and that way everybody could feel okay. Yeah. So, yeah.
There's no harm.
There was no harm.
Yeah.
Yeah. Yeah. But yeah, but I mean, it's like, nobody would have guessed that was behind it without asking.
Right.
So,
And for me, one of the next obvious questions in that conversation would be about what do we expect
yeah.
the outcome to be?
Yeah, I mean, he knew, I mean, the person who wanted this request knew that death was gonna happen. He just didn't want his father to be like, not able to breathe, you know, it just, yeah, so.
Beautiful example.
Yeah, I mean, so that's kind of what we were saying.
Yeah. Any other experiences, thoughts, challenges?
Definitely in the ICU, with not as much with people who have been debilitated and it's been a slow course, but a lot of our younger people with head traumas, trying to talk with families, and especially big families with, it seems like there's always at least one or two with very strong beliefs that if you stop anything that you're killing the patient. We've had a number of family meetings trying to address that, sometimes successfully, sometimes not.
Do you see a pattern in that conversation of what is more effective than others as an approach?
It's kind of been all over the board. One, there was a nephew that was, he just said, if you stop this, you're killing him. And we had to leave, let them talk, went back in, and then we ended up reconvening the next week. Like it was on a Thursday or Friday, we came back on a Monday. But it took a number of times talking to them to help them understand that we're not killing him. I mean, his body is shutting down, his brain is not working. But it took a lot. It just took a lot of conversation.
And sometimes some education can be valuable in that, and helping people to understand there's a difference from the Supreme Court in the act of withdrawing treatment versus the intention of harming someone. So the intent is not to harm, the intent is to provide comfort. And it may be a legal distinction, but for some people that makes the difference, because when you can say there are several cases that have gone before the Supreme Court that haven't addressed these issues, and the Supreme Court has unanimously said, if the intent is comfort, is palliation, then it's not the same thing as causing someone's death.
Right. A lot of what we had to, it was, you know, well, my pastor said this, and then, you know, can we talk with your pastor?
Right.
Yes. Yeah. Usually much more of a religious conviction than anything else.
Those are challenging. And sometimes it's okay to say, we'll just have to agree to disagree, but we can provide support nonetheless. And that's important, because there's nothing worse than working with a family that feels abandoned, that feels like it becomes antagonistic. I think that's one of my favorite conversations about language and reframing is looking at the issue of DNR. A do not resuscitate order is a very active type of thing. It means I'm not going to do something that has potential to be beneficial. Well, who would want that? Just the way that our language is constructed in that argument makes no sense. So I love it when I see physicians that will write an A&D order, which is allow natural death. It's the exact same end. It's just a much gentler approach and an easier way of framing it so that people get their mind around.
How do we get that?
Yeah, I understand that. That's fine. But that do not resuscitate something, no, that's framed as a negative, and so it makes it harder for people to grasp. So sometimes I think it's a cultural thing, if we can just figure out what language that we're using and reframe that to make it something that's okay. And that might be a question to ask. Can you see a context in which it would be acceptable not to do this? Good dialogue. Any other thoughts? Comments? Very good. Mark, thank you. Jim, thank you very much. I appreciate your time.
Thank you for making time to come over here on your busy day, so really appreciate it. Everybody here is going to get an evaluation online. Please complete that. And if you haven't signed in, please do so now before you leave, so you can get that evaluation. And thank you so much for coming.
And do the evaluation. I don't have one.
Are you still a hospitalist?
Thank you.